My name is Britt Östlund, and I have the pleasure to share this first session that will be on person-centered care. And I am a professor emerita at the Royal Institute of Technology, KTH, here in Stockholm. And I have spent my research career focusing on the role of technology in old people's lives. And the previous 10 years developing a subject here at KTH with the title Teknisk vårdvetenskap, Technology in Healthcare. So, in this session, we have two presenters of new and highly relevant research results in this area, and followed by two discussants. So that will be very interesting to listen to you. And the discussants will comment and provide constructive criticism, and I encourage you to think about what would be interesting to pick up in the end of the session, that we can have a discussion. I think we will have at least 20 minutes, according to Amaya, to do that. Every presenter have 20 minutes, and the discussants have 15 minutes, and I will help you by showing you a sign where it's 2 minutes left. So I will be quite careful with the time, so we give everyone the chance to speak. So let me introduce the first speaker, Annika Söderman, that will be with us on Zoom, right? Yes? Annika, are you there?
Yes, I'm here.
Okay. Can we see you?
I think you can see me. I have my camera on.
I think you have the camera on, but I wonder, can we see her? Yes, I think so. Technology is not always that quick. Oh, hi, Annika.
Hi,
welcome.
hi.
Welcome to us.
Thank you.
Annika Söderman has a PhD in healthcare sciences at Örebro University, right?
Yes.
And you are part of a DCI research group. And you are going to talk about dignity conservation in home healthcare and special housing.
Yes,
and after that, Lena Malmstål Hammar, professor in caring sciences at Mälardalen University, will make her comments. So please, Annika, I give the word to you. The floor is yours.
Yes, thank you. I will first try to share my screen with you. So, can you see my screen? I guess so. So, thank you for inviting me to this symposium. My name is Annika Söderman, and I'm a healthcare nurse with a PhD in healthcare science. I defended my thesis in September 21, and this presentation will mainly focus on that research. The research considered dignity-conserving care for older persons, and we evaluated an intervention for this purpose. And the intervention is called Dignity Care Intervention, and I will say DCI. So, when it comes to aging and health, the World Health Organization has stated that an ongoing deterioration affects health and creates vulnerability in older persons. After the age of 80, older persons' needs for special housing and home health care are increased. The care of older people are today covered by a palliative care approach, which includes symptom relief, teamwork, communication, relationship, and support to related ones. Usually, older persons are cared for within general palliative care within the municipality of healthcare. Regarding dignity, there are many definitions in the literature. For our project, we chose the philosopher Berkeley's definition because it has a clear connection to person-centered care, which is an important goal within palliative care. According to previous research, person-centered care is guided by the concept of dignity. And when it comes to the concept of dignity, it is important to be aware of that the feeling of dignity is not static. It changes based on the situation and through the course of life. So here are some international figures. And actually, I haven't seen any Swedish prevalence on dignity, but we know from research that serious illness, life changes, depression, attitudes to aging, pain and frailty are components that affect the dignity value. Loss of dignity can affect the will to live, which creates a great suffering for the older person as well as for their relatives. And dignity is also associated with the quality of life, so promoting quality of life is essential in palliative care as well of older persons. And today we know that the palliative care is unequal when it comes to age, gender, and place of care. Older persons have less access to specialized palliative care in terms of specialized healthcare teams and physicians. Consequently, older persons get less qualified care. However, it is challenging for healthcare professionals to provide qualified care, as many of them lack support and continuing palliative care training. Yet, in the Swedish Healthcare Act and in the Social Services Act, dignity is raised as an important value within the care of older persons. Research states, though, that there is a lack of concrete tools and working methods in order to achieve dignity-conserving care. And it leads me on to tell you more about the project for my PhD that was done within the research group of the Swedish Dignity Care Intervention, DCI. And it was a collaboration between Örebro Municipality, Örebro University, as well as with colleagues from Linnaeus University and Region Gävleborg. And here is the overall aim for the project, and it was to evaluate the Swedish Dignity Care Intervention and its implementation. And the DCI is a manual and a working method for nurses. I don't know if you can see that I have this manual here, which we used. And it includes a communication support with associated evidence-based care actions in order to give concrete guidance on dignity-conserving care. The content includes 3 parts: a questionnaire called the Patient Dignity Inventory, reflective questions to communicate with all the persons, and evidence-based care actions related to dignity. And actually, the original intervention was developed and tested in Scotland and Ireland in 2011 to 12. And it was by the Professor Bridget Johnston at Glasgow University, together with her colleagues. And the DCI was then translated and adapted into the Swedish context by the Swedish research group of the DCI in 2017 to 18. And some small changes were done in the Swedish version. Mainly it was some wording in the questionnaire, and we added some more care actions. The theoretical foundation for both the original DCI and the Swedish version was the dignity model by Kochenau. And the dignity model has been described as a therapeutic map that provides insight into the dimensions of dignity. And as you can see, it has 3 main categories: illness-related concerns, dignity-conserving repertoire, and social dignity inventory. It gives a picture of the complexity of dignity. Here is an overview of our project. And the British Medical Research Council guided us in the design of the project. After the cultural adaptations were made, the PhD project started, and it had an introducing phase with an integrative review and a feasibility study, and also a later implementation phase with 2 evaluation studies. And the participants in the second phase were frail older persons with palliative care needs, not having dementia. And we educated municipal healthcare nurses in how to use the DCI. Other healthcare professionals were included based on the planned care, and it was, for example, occupational therapists and assistant nurses. Head and first line managers helped us plan and manage the implementation. And here you can see how the nurses use the DCI. And by starting at the top, first, the nurse, together with the older person, took a decision to use the DCI. Then an assessment was made by the older person's concerns by using the patient dignity inventory. And the patient dignity inventory, it actually measures dignity-related distress. So after that, a dialogue was held by the nurse by using the reflective question to enhance information by the older person's concerns and problems and needs, I should say. After that, a discussion was held about care actions related to dignity, and the older person, together with the nurse, planned the care. Assessments of dignity-related distress and quality of life was made at baseline and at one time during the DCI process to see if some concerns had been alleviated. So, and now some results from our studies. And this is the first study, an integrated review showing that dignity-conserving care are evaluated internationally with different outcomes. And we found that internationally, there was a great focus on illness-related concerns and a less focus on dignity-related or social outcome measures. It surprised us that communication outcomes were not used to evaluate dignity-conserving care, as it is so important within the palliative care context. The second study was a feasibility study, and it showed that DCI gave structure to the palliative care work in home care and was a way to respond to emotional and existential needs, as well as provided opportunity to confirm older people. There were some barriers to the DCI, and it was the lack of resources, mainly time and nursing staff, and nursing not comfortable in holding deeper conversations. The key components for nurses to use the DCI was described as leadership and commitment from first-line managers. They wanted continued training on using the DCI, and they asked for reflection time to be able to use the DCI properly. So, continuing, the first evaluation study, which was from older persons and their relatives' perspective, they described it was good to highlight dignity in communication in healthcare. The meaning of the concept of dignity was, however, not always obvious to them, but dignity was described as related to older persons' preservation of health, abilities, and social roles. And it was stated that if an older person had reached a state of acceptance and had a mental strain, it undermined their dignity. Further, being seen and heard by healthcare professionals, together with a caring atmosphere and meaningful activities, were important for older persons' dignity. What was described as to to be able to achieve dignity-conserving care were adequate resources, continuity of care, and care competence. And the outcomes of dignity-related distress and quality of life of older people were measured and did not change significantly over time. It was only the psychological quality of life dimension that deteriorated significantly over time. And we don't know why, but it may have to do with that older person became more conscious about their well-being during the study. The last study shows that it was difficult to identify older people for DCI, as many were too frail. However, DCI was a way to deal with loneliness and acceptance issues in older people. It provided an opportunity to personalize the healthcare, and conversations became a clearer task for the nurses. However, some nurses had it difficult to grasp how to use the DCI, and they proposed for a gradual introduction and a broader communication training in the beginning phase. Some nurses lacked the commitment of managers. However, they thought it was positive with reflecting sessions with colleagues and researchers during focus group meetings. The two last studies were hindered by the COVID-19 pandemic. It was difficult to adapt new ways of working when there was suddenly more shortage of staff and new tasks to be done. However, it was described that the DCI could lead to pride in nurses and healthcare professionals, as it shows the importance of their daily work. So to conclude, the DCI has its advantages. It contributes to older people feeling seen and that loneliness and acceptance issues can be managed. The feasibility of the DCI, however, depends on the involvement of the healthcare organization and their ability to prioritize conversations with older persons. The implementation strategies need to be developed to reach sustainability in the future. For example, a broader communication training must be provided to help nurses become more comfortable in holding such discussions as in the DCI. And if you are interested, you can read more about this project in my thesis, and it is in DIVA, so you can find it there. Thank you all for listening. Thank you very much.
Okay, Lena, please introduce yourself.
Thank you. So, my name is Lena Marmstad Hammar. I'm a deputy professor at Mälardalen University in Caring Science. I would like to start to thank KI for inviting me here. And I also want to thank Annika for a very nice presentation about the importance of dignity in the care of older people. My presentation is kind of intertwined with, no, it's not intertwined with Annika's research, but we have many connections because our last studies has focused on dignity and also on well-being in the care of older people. And I'm going to give you a kind of an overview of our research. So, Sweden has legalized from 2011 the national fundamental of values, living in dignity and with a sense of well-being should be ensured in the care of older people. Annika had the definition of dignity, and the Swedish fundamental values has a definition of dignity described by Nordenfelt. And Nordenfelt says that all the person's dignity may be violated by others. So staff's way of approaching older people that they care for is very important to not violate dignity. Working with dignity, the staff need to respect and promote personal integrity for older people, self-determination, participation. The care shall be individualized, and you shall have a respectful attitude, of course. Well-being includes meaningfulness, activities, social relations, and so on, and also safety. And in safety, it includes the continuity of staff. Every year, the National Board of Health and Welfare perform a survey focusing on the fundamental values in Sweden. The survey includes performance of care, safety, social activities, attitudes of staff, indoor and outdoor environment in residential care facilities, mealtime environment, self-rated health and availability of staff, and care in its entirety. This is so-called brukarundersökningen in Swedish. The aim of this survey is to support quality improvement in care organizations of older people. So what we did in our research is to look at this survey, and we also wanted to be able to identify persons with dementia. So what we did, we connected the patient register and the medical register to be able to identify persons with dementia, and also the register on granted service time. So our first study we did on this data was a longitudinal study focusing on home care service and the perceptions of dignity and well-being of older people with home care. What we could see was that during 2016 to 2018, it was a decrease over the years. Persons with dementia, women, old age, and those who perceive their health as low were even less satisfied. We also did a study looking at those with assistive products. This could be for mobility, for hearing, or for vision. And what we could see in this study was that persons with assisted products were less likely to be treated with respect. And what we looked at in the data was the attitude from staff and also participation in decisions about their care. They were more likely to be anxious, feel unsafe, or bothered by loneliness. And of course, we wanted to do a study on the COVID-19. And in that study, we focused on loneliness and anxiety. And we looked at both residential care facilities and also home care. And what we could see, it was that loneliness and anxiety increased during the pandemic. This survey, you could answer the survey from the end of March to the beginning of June. And those answered the survey later during that period, they experienced loneliness and anxiety, that it was more stronger. And we could also see that this respect from staff was strongly associated with anxiety and loneliness, and it was more for those that lived at residential care facilities. In a study focusing on only residential care, we could see that the perceptions of dignity was consistent during the year from 2016 to 2019. But we could see that the experience of well-being decreased. If we look at the definition from Nordenfelt, dignity and well-being is kind of intertwined with each other. So to experience well-being, you need to also experience dignity. If you don't experience dignity, it will affect the well-being. We could also see in this study, as the same as in the first study we did, that persons with dementia, those with old age, and those who perceive their health as low, and also in these residential care facilities, those who didn't thrive in their environment were even less satisfied. So not surprisingly, in our qualitative studies, where we asked about what is important aspects in the care of home care service and also to experience dignity and well-being, they said that I want to be seen as a person. We heard this from Anne's keynote speech before also. I want to be involved in the care and also my everyday life. I want to be seen as a competent person. I want to be supported to manage daily life. I don't want someone to come here and do things for me. I want to be supported to be able to manage this myself. I want to be a social being. I want to continue to have my social relations. And I also want to have social relations with the staff that comes to me. And I also want to be seen as a unique person. So I was lucky to have a keynote speaker before me that talked about this person-centered practice framework. Because I can see if we are going to uphold or be able to target the fundamental values of care of all the people in Sweden, we need to work more in a person-centered way. Based on our studies, we don't uphold those values today. And the prerequisites for this person-centered framework, Professor Brendan McCormack was speaking very good about it just previously. But to deliver person-centered outcomes, first the prerequisites and then the care environment need to be considered. The ability to apply the prerequisites is influenced by the care environment. Prerequisites could be work environment, of course, for the staff, but also how the care is organized. Today, we need to, we have this timetable that it will take, for example, given 10 minutes to take a shower. We don't have the care in an individualized spirit today. I think that is a main thing, but also the training of staff, the education of staff, the continuity of staff, of course. Because in the care environment, the social relations and the relations with the staff is very important. We can see that in our previous study, but of course in very, very many studies too. I believe that it's important, of course, that staff have skills, the management, that we have an organizational view on this, on the person's grounded in person-centered care. But I also think it's very important that registered nurses are more involved in the everyday care of older people. Many older people today has multi-morbidity and are in need of advanced care, and which demands medical skills too, along with the nursing, of course. I also think we need to target the individual factors, such as having dementia or other diagnoses or other decline. To be able to target this person-centered care. and thus uphold the standards of the fundamental values in the care of older people in Sweden. Thank you.
Then I would like to welcome the second speaker, which is Sara Ebrahimi from Gothenburg University, where she is a senior lecturer. And she is going to talk about integrating health promotion with and for old people. It's an e-health project, right? And after that, Anna Sandgren will comment on Sara's speak. So please.
Hey everyone, here in the local and on the link. I'm so grateful for being here. First, I want to thank KI and the organizing committee for this arrangement. Person-centered and integrated care for older people is absolutely a crucial issue globally as well in Sweden. I'm going to present our research project, I hope in English and IHOP in Swedish. But initially I want to start with a little background, which I think it is extremely proper in this context. Two main and key questions arise when it comes to person-centered and integrated care in the context of older people. The first one is why should we create a person-centered and integrated care for older people? And the second one is how can we succeed in creating of person-centered and integrated care with and for older people? Yeah. The answer to the first question is quite known. Anyhow, I think that is extremely significant to remind us of these problems and challenges that we are facing within our healthcare systems. Nowadays, we humans survive many chronic diseases. We have better chances to get older and experience advanced age because, for example, because of ongoing escalating development in medical technology and diversity of diagnostic methods. Of course, it's not bad. It's a fantastic development, but it's just one side of the coin. Yeah, thank you. In the other side, we also know that being older, being in advanced age is often associated with increased risk for frailty, multimorbidity, functional impairment, and being dependence of others. Moreover, the statistics indicate that by 2030, the number of people in advanced age will increase by 50%, and while the number of the number of people in working age is expected to increase by only 7%. Consequently, we are facing an unbalanced demographic underweight in very near future. In addition, statistics and reports also show that the cost of reactive care for older people is increasing. For instance, in Sweden, we have a constant increasing unplanned emergency visits in older people, particularly for persons in 80 years and older. So there is a critical need for innovative approaches to promote health and for designing a sustainable healthcare system that is accessible, efficient, equal, and proactive, especially for older people with complex needs. That was a little bit about our challenges and why healthcare systems need to shift toward a more person-centered and integrated care. However, it's important to remind us about our opportunities as well. The situation is urgent, and it doesn't mean that that is locked and unsoluble. Of course, there are many opportunities to take benefit of for dealing with these challenges. I mean that it's enough to only focus on the problems and working reactive. We must stop doing the same mistake repeatedly. And we have to rethinking, and it is time for rethinking and time for redesigning of our healthcare system to utilize the opportunities in more optimal approaches for dealing with these challenges. For example, there is a plenty amount of evidence that show positive effect of working in more person-centered manner. When it's come to person-centered care, we have to ask us, are we talking about same issue, same phenomenon? I want to point out that it is crucial that we at least have the same starting point when we talk about person-centered care. It's time to implement person-centered care based on a clear philosophy and ethic. The researcher with University of Gothenburg Center for Person-Centered Care, JPCC, used French philosopher Paul Ricoeur's ethic as a frame for understanding and implementing person-centered care, person-centeredness and person-centered care. The ethic briefly is aiming the good life with and for others in just institutions. As you see, the ethic contains three essential and interrelated parts. The good life, targeting the aim, with and for others, the approach, the methods, and in just institutions, the opportunities for justice and fairness. Implementing person-centered care according to this ethic is about an ambition and desire to achieve the good life, explicitly in healthcare context, co-creating a personal health or care plan with and for older people. We can only achieve the best health through doing it together. In addition, we must create opportunities to enable working together as equal in the team. Person-centered care is much more than patient-centered care. It is about getting together and building bridges between different knowledge and perspective on what is the best practice and best healthcare for older people. So involving the older people, doing together and targeting the best practice in every unique context is the most important aspect in practicing person-centered care. Furthermore, we must consider older patient as a whole person and entirety, much more their disease and frailty. Older people, despite frailty and comorbidity, have capabilities and resources. According to capabilities approach, which is consistent with person-centeredness, the human's accessibility to resources is one of the important determinants for their capability. Therefore, in the healthcare context, there are many aspects of opportunity we must consider, such as accessibility of healthcare services in proper time, in proper place. For instance, to what extent we create just institutions according to the ethic, the opportunities for our older people, to what extent we provide proactive actions, provide proper information and support to strengthen self-care in older people. and so on. Moreover, accessible and user-friendly digital devices and working together in the interprofessional and interdisciplinary team beyond different healthcare organizations are among the other opportunities we must consider for dealing with our challenges. Back to the our project integrating health promotion with and for older people. I hope project is an example of utilization of this beforehand stated opportunities and implementing of person-centered approach at distance. A research project with an elegant title and content, I think, which has been developed in the partnership with an ambition and desire to create good life, good health care with and for frail older people, with a person-centered ethic as frame. The principal investigator is Inger Ekman, Professor Inger Ekman, and the project, as you see, the financed by Swedish Research Council. We are in Swedish, and the University of Gothenburg Center for Person-Centered Care, GPCC. As I mentioned, the planning and designing of this project carried out in partnership. For example, choice of study design, intervention components, building up an adoption of the digital platform for communication between the staff and the older people, and choice of questionnaire were developed in close collaboration with an advisory group consisting of interprofessional researchers, older representatives, stakeholders, and clinicians. Here you have Birgitta Krantz, our older representative, who has been and still is involved in our advisory group. You can see the overall aim, and more specific, we are going to evaluate the effect of the intervention with the composite of primary outcomes. We are going to evaluate the process in terms of applicability, feasibility, and reach of the intervention. And also we are going to conduct health economic evaluation as well. We have designed the study according to Medical Research Council frame for complex intervention, and the study has a randomized control trial with effectiveness, health economic, and process evaluation. We have developed the project in close collaboration, as I mentioned, with older people's representative, and we have consistent communication with our advisory group. Yeah, we know that frail older people risk being ignored, often risk being ignored and missed within the our fragmented healthcare system and between different organizations. Therefore, identification of frail older people in proper time is crucial. However, a research assistant is responsible for screening of frailty by using instrument so-called FRESH. FRESH instrument we have used, and this instrument, frailty screening instrument, is developed by the Frail Elderly Support Research Group. Our participants are community developing frail older people, age 75 years and older, who have sought the emergency department but not been hospitalized. After oral and written information and consent, they are allocated to control and intervention group. Yeah. In addition to usual care, the participant allocated to intervention group receive person-centered telephone support, and they can communicate with a dedicated healthcare professional, and if needed, with our other research team members or professionals through telephone call and digital platform for 6 months. So the intervention is delivered remotely and is coordinated by a dedicated healthcare professional. Briefly, a dedicated healthcare professional initiates the first telephone conversation shortly after study inclusion, often within 2 weeks. She, with an open mind and sensitivity and imagination, listened to the participants' narrative for comprehend the older person's everyday life and health situation. And further find out resources and health-related goals. Afterward, a mutually agreed health plan with specific and relevant health-related goals and health plan will be co-created, which is health plan is based on what is the important for older person and what is the best achievable practice for use. For this person. In addition, strategies and actions that are achievable to manage everyday life is discussed. On average, we have 4 to 5 person-centered telephone conversation with each participant within this intervention time, 6 months. Regarding data collection, various data sources will be used, among other registered data, clinical and self-reported data by questionnaire consisting of several validated instruments will be collected. As I mentioned, the primary outcomes is a composite of change in general self-efficacy and need for hospital care for hospital for unscheduled reasons, and data will be analyzed both through quantitative and qualitative methods. The project is ongoing. We have started early spring 2020, and it is expected to be completed this year or early 2024. I have to hurry up. At last I want to point out the importance of and relevance of IHOPE. The project has a person-centered ethic as approach. It has been designed and implemented through interprofessional team collaboration in partnership. The hub of this intervention is co-creation of a personal health and care plan based on older person's narrative and the best achievable practice in agreement. And furthermore, the project includes health promotive and proactive aim and actions and utilization, adoption of digital opportunities that have been developed with older people. Thanks.
Thank you, Sara.
Thank you so much for the invitation to talk, and I will connect a little bit with your previous presentation. My name is Anna Sandgren, and I work at Linnaeus University and also at the Center for Collaborative Palliative Care, which is actually a collaboration between the university, the region Kronoberg, and the 8 municipalities in our region. So we work really close in our palliative center. So I'm the director of this center. So if you are interested, please look into our webpage. We work with person-centered care with 4 different areas. It's education, it's clinical development, and it's research and public engagement. So I was looking a little bit at your presentation, Sara, and I was looking at your aim, and it's a really interesting project, I think. And I was looking at your aim, and I saw that you're going to evaluate effects, describe the process, and also do some evaluation. And we know a lot about intervention themselves, and we know also that it's sometimes difficult. We know that it has effect, but what about the implementation? We have heard it a little bit before about the implementation and the importance of the implementation itself. So here you mentioned also that your project is guided by this article about complex intervention. And I think that we need to focus more about the implementation in the future, as previous speakers has talked about. And also when I searched a little bit about what's going on, I found this scoping review that is actually quite interesting. I don't know if you have seen it. It's about barriers and facilitators, about using e-health for older persons. And they conclude that further research is needed to explore the practical and conceptual barriers and facilitators for older adults. So there's a lot of things that we need to be done. So I also looked at some of the key elements in your presentation, and I found that person-centered care, you talked about health promotion, you talk about communication, complex intervention, and implementation. So I thought, how can I connect that and what we are doing in our center? So I want to continue with that, about talking about serious illness conversation. And why should we talk about serious illness conversation? We can see that patients say that, don't think you know who I am if you haven't asked me. This matters to me. So why talk about serious illness conversation? We can see in the national guidelines and documents right now, we have the concept in our documents. It's samtal vid allvarlig sjukdom. And there's a little bit of confusion. What is actually a serious illness conversation, and when should it happen, and for which people should we have them, etc. So you can see it's in both of these documents in Sweden. And what is actually a serious illness conversation? And we have worked for 5 years in our center with this. And we have taken a program from Ariadne Labs in Boston, US, and we have adopted it a little bit. And we have given it a definition. So here you can see the recent definition that serious illness conversations are structured conversations. They are offered at an early stage of the disease and then as needed. And the patient's and the relatives' needs, strength, and wishes and priorities are in focus. And also information about the course is given based on the patient's wishes and in order to plan continued care. So the aim of the serious illness conversations actually are to promote the opportunity for patients and relatives to live with dignity and well-being. So that's also connected to Annika's presentation. So this is an overview, a very simple overview of a serious illness care program that we have called the Kronoberg model, since we are in Kronoberg. It's different parts, but you need to identify which patient. And here we focus mostly on palliative care, but it could be also patients not with the end of life. It could be, for example, if they have a critical loss, it could be loss of the sight or loss of some function. So, but we focus mostly of palliative care. And then it's the conversation itself. And then also, according to a conversation guide, you can see it down here. And we have a family guide and also a preparation letter. And then it's necessary to have the documentation so everybody can see what this conversation has been about. So what is then the conversation? What is the central elements of the conversation itself? Because what is needed to be a conversation? And we have here the guide that we have translated back to English, so you can also find it on our webpage and also at the Ariadne Labs webpage in Boston. So the elements is to explore patients' understanding of their disease, and then also discuss the patient's thoughts on what's important now and moving forward, including hopes and fears, and provide information the patient desire about expected course, not what we think is important. And ask about family involvement and needs, and also suggest a plan based on the wishes and priorities, but also on your professional assessment. And we talk about the future from two perspectives: hope for the best and prepare for the worst. Because we can see in previous research that this perspective is good to talk about some topics that could be sometimes a little bit sensitive, to have these two at the same time. So this is a little bit what we have been doing in our center. We started in 2017, and we started it as a quality improvement project. But we have also done some research on that. And we had the conversation guide, but it wasn't adapted. It was adapted, but not validated. And so we have started again in 2021, and we also now include the whole team, not just the specialist physicians, it's all the physicians and the nurses. And we have translated and validated all the guides again in a more scientific way. And we have adapted the guide a little bit more from the original version from Boston. And we have also some research going on, quite a lot actually, and we have done a pilot study. So we can see in some of the studies we have done that something that is quite difficult for the physicians and the nurses is that it's how to identify and then to have the conversation. And you can see from one of a study that identifying the right patient at the right time involves existential and ethical concerns which may impact healthcare professionals' willingness to identify patients and offer serious illness conversations, because they are afraid to take away the patient's hope. So they need also to be confident in having these conversations. And that could be some good way to have these two perspectives, hoping for the best and prepare for the worst. I also talked about the implementation and the importance of the implementation. And we have looked at the implementation, and we think that how can we make it sustainable? Because we know that so many different interventions we do, they have effect, and we can see a positive effect, but then it ends. I mean, how can we make it sustainable? And we also think that systemic changes, we need to work with the whole organization. And how can we make it sustainable? What are the implementation strategies for this kind of interventions? And what are the hinders and facilitators? And we also looked at the organizational readiness for implement serious illness care program. And what are the barriers and what are the enablers or facilitators? And we can see that the leadership is crucial, is a key element. And also the time, of course, but the confidence to have these conversations, to feel confident that I can have it, and also know the importance of the conversation. And also how to identify and when to have the conversations, because we can see that when we introduce it, all of them say that, oh, it's so important, but then it's difficult to have the conversation. And also the attitudes. So I think changing attitudes is important. So this is what we are doing right now. We are focusing more now on implementing it for the whole team and look at both from different perspectives, but from the organization also as well. And looking at implementation and the outcomes. So if you want to know more about our work, about serious illness conversations, please look into our webpage, and here you can see some of our published articles and submitted in manuscripts. So we are doing a lot about serious illness. Thank you.